good evening, friends. Welcome to ACNS webinars. Say very good morning and good afternoon to our distinguished speakers, and good evening to our honorable chairs and friends in Asia. Welcome to ACNS webinars. We have two very interesting topics coming up ahead. The first speaker for today is no stranger to us, as he is one of the most famous names in the neurosurgery circuits, Professor James Rutka. Professor Rutka is the professor in the Department of Surgery and chairman of Division of Neurosurgery at the University of Toronto. He was the past president of the ACNS and he is the editor-in-chief for the Journal of Neurosurgery. Professor Rutka has been on the forefront of the online neurosurgery education even before the beginning of the pandemic. He has received several prestigious awards and honors in his illustrious career, including the Order of Ontario, which is the highest honors awarded to a civilian in the province. He is the director of the Arthur and Sonia Labat Brain Tumor Research Center at the University of Toronto. His recent clinical interests have centered on the surgical treatment of epilepsy in children. He has over 400 peer-reviewed publications. We are so honored to have him today as a speaker at webinars. Today, Professor Rutka is going to talk about evolution of epilepsy surgery, lesson learned from last 30 years. The second speaker for today is our honored guest from Sweden, Professor Michel Farrisko. Professor Farrisko is a part of the Center for Research and Bioethics Neuroethics research team. As a postdoc researcher working in consciousness, artificial intelligence, and neuroethics within the Human Brain Project. He was appointed Associate Professor of the Moral Philosophy in Italy. He holds a MA in Philosophy from the University of Naples. And Professor Farrisko is the head of the Science and Society Research Unit of Biogen Genetic Research Center in Ariano, Irpino, Italy. He has written 3 books and several articles about post-human philosophy, philosophical, ethical, and legal implications of genetics and neuroscience. Professor Farrisko is studying the ethical and legal issues emerging from neuroscientific investigations of disorders of consciousness and related technological applications. The project is a part of the European Union flagship Human Brain Project. We are so thankful for him for accepting this invitation to be a speaker at webinars. The chairs for today are our distinguished guests from Japan, Professor Yasukazu Kajita and Professor Tomohiro Yamaki. Professor Kajita is a senior professor in neurosurgery at the Nagoya Hospital Organization, Nagoya Medical Center, Japan. He is a very senior member of the Japanese Neurosurgical Society and his primary research interests involve functional and epilepsy surgery. Professor Yamaki is the director of neurosurgery and PET imaging division, Rehabilitation Center for Traumatic Appendix, Chiba, National Agency for Automotive Safety and Victims Aid, Chiba, Japan. He is a member of the Japanese Neurosurgical Society and International Brain Injury Association, Disorders of Conscious Special Interest Group. We are extremely thankful to both the chairs for accepting an invitation to chair this webinar. On behalf of the Education Committee of the ACNS and the President of Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online platform of ACNS webinars. Dr. Yu Boon Singh from Malaysia is my co-host for today. And with that introduction, may I please hand over the dais to our first chair, Professor Kajita.
Thank you for your kind introducing me. So now I'm so happy to introduce the Professor Rutka, who was the first CIGTA scholarship at Nagoya University. Actually, I worked at the Nagoya University. So today's his talk is about the epilepsy surgery. So please start your lecture, Professor Rutka.
Great. Thank you very much, Professor Kajita, and also thanks to Raja for organizing today. And it's a real pleasure to take part in the ACNS lecture webinar series. I have had the great pleasure of interacting with the ACNS over many years and attending various congresses, so it's a real pleasure. You know, I've been doing neurosurgery for 30 years or more now, and I guess about 25 years ago, I took over the epilepsy practice of surgery at Sick Kids Hospital, where I work in Toronto. And I just wanted to talk about the evolution of neurosurgery techniques in epilepsy, because it's evolved in an extraordinary way. And I thought it would be of interest to the group. So I'm going to start my presentation. I hope you can see my slides. And more importantly, I have a few videos. Hopefully they'll turn out okay. Sometimes the videos are a little bit tricky on webinar platforms, but let's begin and talk about how things have evolved. I have nothing to disclose for this presentation, but I do want to acknowledge that to do epilepsy surgery, you need a very big team to do it well and to do it in a sophisticated manner. So we have neurologists, we have neurosurgeons, neuroradiologists, neuropsychologists. We use intraoperative neural monitoring, navigation, and we have a number of nurse practitioners helping us on the epilepsy service. The novel technologies about which I'll be speaking today include many of these. So magnetoencephalography, monitoring, high frequency oscillations, diffusion tensor imaging, focal cortical dysplasia, bottom of sulcus dysplasia, stereoencephalography, and laser interstitial ablation. We probably have the world's largest experience for MEG, magnetoencephalography in Toronto, and we've used it for well over 25 years now. And unlike the other imaging modalities that you see here, MEG has the highest spatial and temporal resolution. And so it's an excellent tool, especially when trying to find the epileptogenic origin of select cases. You know, we've also provided some guidelines on what signifies a relevant MEG pattern. And so clusters are, we think, very important, where you have more than 20 spike sources. But then you have these other variations in the way that the MEG traces can look. And sometimes it doesn't provide as much information as, for example, when you have a major MEG spike cluster. And this is work that we published in the Journal of Neurosurgery many years ago. The trouble with MEG is that it's not done on an ictal basis. Typically, it's usually interictal. So it's hard to know exactly what interictal MEG data mean, but occasionally you can get an ictal MEG, as with Rasmussen encephalitis, where the brain is seizing all the time. And you can see this tight cluster over the Rolandic area in this child with Rasmussen encephalitis who required a hemispherectomy. And we know from our experience that in this particular example of a child who had a brain injury, post-traumatic injury, you can see at the junction of the encephalomalacia and where the brain is found, you can see this spike cluster here. And removing this spike cluster by itself using image guidance can be enough to help with seizure control. So that's how we use MEG in our practice. I'll next move to intraoperative monitoring. And it's to map out the primary motor and somatosensory cortex and to determine what's functional and non-functional while doing surgery. And this is done in order to prevent major neurological problems to patients during surgery and to provide feedback and reassurance to the children on whom we're operating. And we have a very capable, very excellent technician who leads our intraoperative neuromonitoring team in Toronto. In terms of mapping eloquent cortex, we've been publishing a number of papers over the years looking at various things like monopolar trains of 5, pre-surgical localization using MEG, mapping the cortical spinal tracts with DTI. We've essentially shown that navigation plus monitoring plus epilepsy surgery can be very effective, including awake craniotomy. And we can do awake craniotomy in children as young as age 4 at our hospital because we have very good neuroanesthesia and also excellent psychologists helping us with the procedures. But typically we're doing awake craniotomies on older children ages between 6 and 20. The modalities we use for intraoperative monitoring are the phase reversals, direct motor cortical stimulation, subcortical stimulation, and for monitoring continuing direct cortical stimulation, EEG, to identify stimulation induced after discharges. So the trains of 5 was a really good technique because it doesn't have the same incidence of seizure onset if you're using it intraoperatively as the Penfield technique, which you're familiar with, the monopolar technique. So the bipolar technique is actually very good for mapping and for monitoring, we find, and we're able to map out the cortical spinal tracts, which you can do with the trains of 5, but not so easily or well with the Penfield technique. And just to show you a case where things are going along very nicely, you can see here in these muscle groups with EMG recordings, but then suddenly we have a loss of activity, wondering what is going on with the monitoring. Turns up we were using too much brain retraction. When we limited the brain retraction, we could see the recovery of the evoked potential monitoring that we were using. So it can be a feedback for the surgeons and can help us with the recovery phase if we are alerted to the fact that these patients are running into some challenges with loss of evoked potentials at the time of surgery. And there's subcortical stimulation. This is an example of a child who has polymicrogyria in the insular area, you can see here. And the cortical spinal tracts are going to be found here. So you can imagine by taking this away at surgery, you're coming very close to the cortical spinal tract. And so it's extremely important that you have at your fingertips subcortical stimulation so that you can stay safe and avoid injuring the functional motor pathways. I just want to say a few words about high frequency oscillations. These are electrical changes in the brain that occur that can be measured. The normal rhythm of the brain is about 30 hertz. So when you're up to like 80 to 150 hertz or over 200 hertz, we call those ripples, and we can characterize those using subdural grid monitoring. And the presence of these high frequency oscillations often precedes a seizure onset. So the high frequency oscillations are related to seizure activity. Here you can see as the line is coming across, you can see the activity in the brain where the high frequency oscillations are occurring. And we know that that's the sort of ictal onset zone when we do our measurements of high frequency oscillations through invasive subdural grid recordings. We've published a lot of papers over the years on the use of the high frequency oscillations and their value. We're still using it to this day and find it helpful at times for us. But as I'll mention towards the end, we've moved away a little bit from doing subdural grid recordings now to doing stereo EEG recordings, which I'll be elaborating on later. Limitations of the high frequency oscillations, we really don't know how they relate to underlying seizures. The neuronal mechanisms aren't clearly worked out, and we don't have yet long-term follow-up data, but those will be coming in the future. But there is an association between high frequency oscillations and seizure onset and the ictal onset zone. And this is something that we've pursued at Sick Kids Hospital over a number of years. Okay, just now to move to diffusion tensor imaging and epilepsy surgery. This child who had hemispherectomy but had a relapse after being seizure-free for a number of years. And by using DTI, we were able to show that there was one area still of connectivity here at the very ventral portion of the cortical spinal tract, as shown here on the DTI. We found this to be a useful technique to help us understand disconnections between the two hemispheres by using DTI. But DTI can be used for lesional cases like this. You can see in proximity the lesion with respect to the cortical spinal tract in yellow. Same thing here. These are all different cases that we used DTI for to help us understand precisely where the cortical spinal tract is. And you can understand that linking this with neuronavigation and with intraoperative neural monitoring makes your surgery as safe as possible. Okay, next is bottom of sulcus dysplasia. And this is a relatively recently understood pathology that is focal cortical dysplasia, typically type 2. These lesions are sometimes very hard to see. They're very subtle, and often you need a trained neuroradiologist to see them because they're so subtle. But they do represent a possibility for a seizure onset zone. And these are a number of cases in our series where looking at in the area around the yellow boundaries here, what you can see, very subtle disturbance of the cortex. And our neuroradiologist, Dr. Wajaja, is able to identify these. And here's an example of a bottom of sulcus dysplasia that was embedded within the cortical spinal tract and posed significant surgery risks at surgery for us, but we were able to proceed to surgery for a case like this, knowing that we were going to be resecting an area of the bottom of sulcus dysplasia. Okay, invasive subdural grid monitoring. Dr. Carter Sneed at our institution has been using this technique prior to his arrival in Toronto in 1995. This technology has been around for quite some time, and it requires craniotomy, placing a large grid that you can see here, an ability to map out all the various functional areas, including information preoperatively obtained from the MEG, et cetera, cortical stimulation information, and so on. So it's, it's very valuable, and we did this for many, many years. And by taking photographs using digital camera technology back in the 1990s, we were able to show that everybody can see the picture. Everybody knows exactly what's going on with the mapping of the brain and the determination of where the seizures are coming from. But there are some complications associated with subdural grid monitoring. We publish, these sometimes are large craniotomies. We often supplement these with depth electrode recordings that you can see here. But by and large, we were able over the years to determine, a very good way of doing this. And more recently, we've been using stereo encephalography, as shown here, as a lot of groups in North America now have been moving to SEEG as opposed to subdural grid monitoring for all the reasons that I think you can imagine, and that the techniques are a little bit different, but the information that is derived from both techniques are very similar. And the procedure for SEEG is very well tolerated, and children do extremely well when they undergo these procedures for epilepsy. I'll have a case at the end to show you. But anyway, here's laser interstitial thermal ablation. And so we've been using the laser now for the last 3 or 4 years in Toronto. It's MR guided therapy. We have a laser probe. Typically, we use a frame-based technique, usually the Lexel frame. Our experience is growing, a lot of experience in adults, especially with tumors. But it's also good for epilepsy. And these are some of the indications. So mesial temporal sclerosis, subependymal giant cell astrocytoma, periventricular heterotopia, cortical dysplasia, hypothalamic hematoma. And there are 2 main systems on the market for laser ablation. One is the Monteris or NeuroBlade system, and the other one is the Visualase system. So you need to decide which of those 2 systems you wish to pursue. And I would say that, they both have advantages and disadvantages. But the publications are coming forward now for their use in hypothalamic hematomas, for epilepsy, and more information is being derived even for insular epilepsy and laser ablation. And at the end, I'll show you one of our cases for insular epilepsy. But to get going with laser ablation, you need a dedicated MR, preferably an intraoperative MR. I mentioned the 2 systems that are on the market. You need, be nice to have navigation abilities. You need a workstation, like a stealth platform for planning, and a team, as mentioned at the beginning. And unfortunately, it's expensive. So this technology is not something that developing countries are going to find easy to purchase just because of the cost. But we are definitely finding applications for this technology that makes it extremely worth our while for these children with intractable epilepsy. And there's our intraoperative MR unit at the Hospital for Sick Children. Just some images. So the Lexel frame is placed. Draping around so you can do the laser ablation is critical. Access to the scanner afterwards and the planning station are things I've already mentioned that are extremely important. So I'm going to show you some cases and also some series of patients that we operated on so-called regional epilepsy surgery. So the first regional epilepsy surgery is frontal lobe epilepsy. And frontal lobe epilepsy is very challenging because the frontal lobe is vast. It's large, and it's really hard at times to pinpoint precisely where the epilepsy is coming from, especially when it's non-lesional or you don't see where the frontal lobe is involved. There were certain pathologies that you can see here in our series, and we had a number of children here. Cortical dysplasia was the most common pathology. Outcomes were about 60, almost 65%. And I mentioned the problem about non-lesional cases. This is a video. I just wanted to show you a video if it shows a frontal lobe epilepsy so you can see what a frontal lobe seizure looks like. So this child will just start suddenly having hyperkinetic movements, and you'll see that this is now the seizure starting. And this seizure started from the frontal lobe, and we were able to do a frontal resection, and this child did extremely well after the surgery. These are some examples: frontal cortical dysplasia, focal cortical dysplasia, a bottom of sulcus dysplasia. You can see this cleft that's coming down here, and it's not present on the other side. Another area where there's focal cortical dysplasia and a ganglioglioma, DNET. So these are the pathologies that you typically see. Okay, next is temporal lobe epilepsy. And whether it's adults or children, the temporal lobe is very frequently involved in seizures. And as a result, we have done a lot of surgery over the years in temporal lobe epilepsy for children. Interestingly, mesial temporal sclerosis is not as common for sure in children as it is in adults. And often there's dual pathology in children, combination of dysplasia and or tumors like DNETs together. But the good news is that seizure outcome is much better for temporal lobe epilepsy, on the order of about 80%. And I've mentioned some of the pathologies here, and we published our series a while ago, and we've clearly doubled the number of patients that we've seen now over the years. Here's an example of mesial temporal sclerosis, and this is before and after surgery, where the mesial structures are removed that you can see here. And here's an example of a lesional resection for a ganglioglioma that was present in the mesial temporal lobe. Sometimes for a mesial tumor, I'll choose to use a trans-Sylvian approach. And here's the pre-op. You can see the tumor here. Here's the post-op. It looks like the tumor has been removed. And this is a video showing the trans-Sylvian, so splitting the Sylvian fissure, coming down mesially and resecting the tumor. A nice approach. It almost looks like there was no surgery performed here on the right-hand side because of the non-invasive way that the brain was approached through the trans-Sylvian. That was a ganglioglioma. So the results after temporal lobectomy for temporal lobe epilepsy are usually very good. But if you follow your patients long enough, like 5 or 10 years, you'll see that there can be a worsening in seizure outcome. So 2 years is probably not long enough to truly follow your patients with temporal lobe epilepsy. You need to understand the results at 5 years and at 10 years. So temporal lobe surgery can be performed, and good expectations of outcome. Ganglioglioma tumors, lesional cases have excellent outcomes when you remove the lesion. Children with cortical dysplasia don't do quite as well as those with tumors, usually because the dysplasia is quite diffuse, but not always. And if you follow your patients long enough, there can be some relapses. So I think this is the type of surgery that all neurosurgeons around the world should be able to do, especially if there's a lesion. You should be able to take out the lesion and help the patient with seizures. And that's something that would do the world a big service if neurosurgeons could get very familiar with the technique of temporal lobectomy worldwide. Neuropsychology is important, especially if you're planning to remove the mesial structures. Okay, occipital lobe epilepsy in children. Our series of patients here, this is a category of seizures that typically affects the optic pathways, so that visual auras and scintillations and things become very, very common in presentation. We use all these various diagnostic modalities to identify precisely where the seizure is coming from. And you can have Sturge-Weber, cortical dysplasia, tuberous sclerosis, gliosis, and so on in these cases. And oftentimes they are confined to the occipital lobe as shown here, but sometimes they can be combined with the temporal lobe or parietal lobe. So we did our analysis. This was isolated occipital lobe epilepsy. You can see the cortical dysplasia here in the right occipital lobe. So resecting this led to good outcome. But then you can have cases where there's involvement of both the occipital lobe and, as mentioned, the temporal lobe. So you can have to do multi-lobar resections at times where the occipital lobe is involved. Okay, the next regional epilepsy type is Rolandic epilepsy, and this is one of the most challenging and difficult types of epilepsy to treat. And Luigi Rolando, in terms of history, was the first to recognize the central origin of the brain. And he wasn't able, however, to connect what this portion of the brain was doing, but he recognized that the fiber bundles were all kind of coursing in the same direction. And so after him, the Rolandic region was named. And initially we looked at Rolandic Sylvian epilepsy, and we found a number of children who had seizures arising from either the motor or the somatosensory cortex. And for a while, when we saw these cases, we were doing this technique called multiple subpial transections. And here's a video that shows you how the multiple subpial this was good. Short-term outcomes were actually excellent, but the problem was within 6 to 12 months, most of the patients had recurrence, at least of parts of their seizure types. And after many years, maybe 5 to 10 years, this has now fallen out of favor. That said, I just did a case about 2 weeks ago where I had no other option but to do subpial transection. So it is a technique that you may wish to know how to do in those cases where you can't resect around or in the Rolandic region. It helps to preserve function, and it takes away the problem of having persistent seizures afterwards. Here's a child who had this cluster over the Rolandic region. We did invasive monitoring. We found this region of the brain was involved. That was in the somatosensory cortex. We did a resection here that you can see, and the child has been seizure-free for many, many years now, and has had a great outcome. So that an example of Rolandic epilepsy that you can use. And we published our series a while ago, leading up to the present time, but the number of patients who did well was pretty small by comparison, and there were many failures. But the important thing is that these types of patients have seizures that are occurring, dozens, if not hundreds of times a day. So if you can improve their seizure outcome by 90% and reduce the number of seizures by 90%, it's not going to put them into Angle 1 outcome, but it gets them into a much better quality of life. So this is a seizure region that is very challenging, but sometimes we've done very extensive resections that you can see here, with expected outcomes, with possible hemiparesis, with possible other manifestations. But seizure control is better typically than preoperatively, and big discussions have to be had between the families and the surgeons and the epilepsy team before you choose to do that. Okay, well, I think this is the last regional epilepsy, and this is insular epilepsy. And this one is very tricky, very challenging. And we published some of our efforts on doing insular epilepsy here, where you can see doing an open approach. We've been skeletonizing the insular region, taking out the insular cortex. It's a challenge. There's a certain semiology for insular epilepsy that you will need to be familiar with. And these patients are often very hard to identify where exactly in the insula the seizures are coming from. But stereo EEG is great for this, and also now laser ablation. I'll show you a case at the end of laser ablation that we used to help with insular epilepsy control. Corpus callosotomy is a palliative type of procedure. We've been doing this for many years, and it's very important that you decide up front whether you do a complete callosotomy or you do anterior 2/3 callosotomy. I think the best results clearly are from a complete callosotomy. On occasion, for children who might have very intact language and fairly intact cognitive performance, we might think about an anterior 2/3 corpus callosotomy. And this diagram here was drawn by Ian Sook, who's a medical illustrator now at Johns Hopkins. But just to show you that the corpus callosum is segmented, and you can see the various parts of the brain and where they cross to the other hemisphere from this diagram. I'm not sure we'll show this whole video, but this is the intra-hemispheric approach to a corpus callosotomy. You can see opening now right on the corpus callosum. It's very easy to open the corpus callosum with bipolar or just a dissector, and you have to get the entire, rostrum all the way back to the splenium. The splenium is the hardest part, and there you can see the vein of Galen at the end. There's the vein of Galen. Now you know you've gone through the entire corpus callosum. This patient also had tuberous sclerosis and a subependymal giant cell astrocytoma. So we did a callosotomy and we removed the sega at the same time. Here's an anterior 2/3 callosotomy, and here you can see a complete callosotomy that's been performed. I usually get imaging after surgery to be sure that the callosotomy is complete. The splenium of the corpus callosum sometimes can be curved downwards like this, and it can be a long reach. So you need to study where the corpus callosum is in all your patients if you're going to do this type of procedure, because it's a long reach from the coronal suture that you see here all the way down to the splenium. But it can be done through a single approach, and I've done many, many cases like this. And outcomes after callosotomy, well, the seizure type is for atonic seizures typically, so drop attacks, and this is a very good technique for that. I won't say much about hemispherectomy, but we do a lot of hemispherectomy at our hospital for these conditions here: Rasmussen, Sturge-Weber, hemimegalencephaly, cortical dysplasia, and infarction syndromes. And you can see on the MRI scans what each of these looks like. We've gone from doing anatomic hemispherectomies now to very small window hemispherectomies, including the parasylvian approach and now the vertical hemispherotomy approach. So many different techniques available. Okay, I just want to conclude with just a few cases. Here's Rolandic epilepsy. You can see this lesion abutting the cortical spinal tract, 4-year-old with motor seizures, and was coming on the dominant hemisphere, we thought. So we did invasive monitoring. We put a grid down, put depth electrodes right into the area where the lesion is located. Here's the seizure. She's holding her hand because left side, it's her right hand that's bothering her, starting to twitch. And so that's the seizure that you can see. This is the high frequency oscillations, and the video of this showing where the high frequency oscillations are occurring, exactly where the depth electrodes have been placed. So we knew that this was the area of the lesion, and went for a resection. Here's the postoperative image. We used trains of 5 neural monitoring and got excellent resection. She had a very transient weakness after surgery, but it had resolved within a week afterwards, and balloon cells and focal cortical dysplasia. This was excellent outcome, no seizures after this procedure. Another case, small area near the cortical spinal tract. This looks like bottom of sulcus dysplasia that you can see here, and multiple medications. Here's the epilepsy map. We used subdural grid recording and depth electrodes both together. And we did a resection of this lesion using navigation because it was at a depth, and navigation and leaving the depth electrode in the lesion that you can see here as you're approaching it allows you to find and be certain that you've got the target, because without, even with navigation, finding that target, that small area of cortical dysplasia, is actually very challenging. So in any way, we published on that, and this is a good way to help you find these small lesions. And this is the case I showed earlier, where we're resecting this area of cortical dysplasia in the bottom of sulcus, using these depth electrodes as guides right to the lesion. And here we're taking a biopsy of that lesion, and then you'll see we'll be removing it. It's clearly different, has a different texture than normal cortex, and we stayed right on target, used a transsulcal approach to get there, and the result was seizure freedom afterwards. So here you can see depth electrode placement in management of bottom of sulcus lesions as a technique. Another tumor here, cortical spinal tract, 4-year-old, like sensory seizure signs from this left-sided lesion. This is how we mapped it out prior to surgery. Here's the video at surgery resecting this lesion that turned out to be a ganglioglioma. You can see the clear difference of this, the texture of this tumor compared to the surrounding brain. But it was right up against the diffusion tensor imaging cortical spinal tract, so we had to be very careful with neural monitoring. There's the after surgery, and this child has done extremely well. A small hypothalamic hamartoma, here it is. You can see it at the base of the hypothalamus, 2.5-year-old with Lexel frame, the draping, trajectory, laser bolt. We passed it in and we got excellent seizure control from doing a laser ablation of that lesion. And this last case is a stereo EEG workup for an 8-year-old male with non-lesional epilepsy. And all the information on what our preoperative workup looked like is on the left-hand side here. And this is the hypothesis that we had. This was the array of electrodes. We used mostly right-sided, but some on the left side. And this is what it looks like at the time of the implantation, the array and the trajectory of the different EEG electrodes. But it was the right posterior insular electrode that was the ictal onset zone after all of our workup and investigation. So we decided to do laser ablation, and here's the image after the ablation showing the ablation of the posterior insular cortex and on the flare signal here and here. So I've done these insular resections open. I've done them with laser now, and I must say that laser is way better tolerated. It's I wouldn't say it's easier to do because of the setup, but it's probably better for the patient. And this particular patient, it's early, 6 months now, is seizure free. So, okay, so that kind of wraps up the presentation. This is now coming to conclusions for everybody. We've had diffusion tensor imaging, MEG, cortical dysplasia, bottom of sulcus dysplasia. I talked about having your MR linked to navigation, the importance of considering what type of monitoring technique or mapping, whether it's surface or depth electrodes. We've been moving gradually over to stereo EEG recordings. There's new technologies. We're about to get the robot for stereo EEG. We decided that we would move into getting a robot to help us with the placement of the laser. And there's a new technique called responsive neurostimulation, which I'm not going to talk about today, but an attempt to try to stop seizures with an implantable electrode array, and kind of like a vagal nerve stimulator, but cranial based, and is being done in a number of centers. And there's a gradual trend now towards minimally invasive neurosurgery. So you can see a variety of techniques arising where either the endoscope or small opening craniotomies, minimizing the amount of surgery, laser, etc., for getting the best results possible for our patients. It's going to be important for us to continue to monitor our patients longitudinally and determine what our outcomes are as we go from these big procedures to smaller procedures. Okay, with that, I'm done. And I just want to thank you again for the invitation to speak to you. It was a real pleasure to spend some time with you. I'd be happy to answer any questions that you may have.
Okay, yeah, thank you for your wonderful lecture. So I'm so impressed the great advance in epilepsy surgery. So you talked about a lot of things in the intraoperative monitoring. So high frequency oscillation and the diffusion tensor imaging and SEEG and MRI guided ablation. So actually we have a lot of the great technique for the epilepsy surgeries. So in our university, so we purchased the robotic system for SEG, and SEG actually started, but the laser ablation is not available in Japan still. So my question is, unfortunately, in some Asian countries, some expensive device or instrument is still not available. So actually, when I talked about epilepsy surgery in some countries, they asked me to how do they operate epilepsy surgery in such a situations. So do you have any suggestion to answer?
Yeah, thank you, Professor Kajita. Very good question. And laser is expensive. It's not available. So what's the possible solution in some countries that don't have opportunity? So I think, and I've seen many good examples of using radio frequency ablation for cases that we would use the laser for. So even including hypothalamic hematoma, insular lesions, you can insert your electrodes to target and use radio frequency stimulation and ablations to get a similar result. The problem with radio frequency, in my opinion, is that it's not as precise and you can't visualize the area of the target so well as you can with the laser. And what I might do, I don't know if it's worthwhile for the audience, but I do have some examples of the laser in action. So if you just give me 1 second, I can pull up and show you an example of how the laser works in real time and how you can actually visualize what the laser is doing at the time of surgery. So 1 second here. Yeah, so I'm just going to share screen and I'll show you this one case and you can see hopefully what's going on. So this is a hypothalamic hematoma and this is the laser ablation. It's a massive hypothalamic hematoma and we've placed the laser probe into the hematoma and you can see in real time, like we're watching this happen, how the temperature is rising. In yellow at first is 43 degrees centigrade and then 45, 46 up to 50 plus centigrade is in blue color. And the blue color indicates where you're going to get necrosis. And you can see that we put a pink circle around where we wanted to do the ablation. And we keep on using the laser until we fill up that volume and we get excellent results from this type of approach. So that's the value of the laser as you see it in real time, but with radio frequency, you don't see it so nicely like that.
Great, thank you. Actually, in Japan, so Niigata Hospital, yeah, they have a lot of cases of the radio frequency of the hematoma. Yeah, and I'd like to talk about SEEG. Yeah, actually, I visited the University of Toronto maybe 20 years ago.
Oh yeah.
Dr. Otsubo took care of me.
Yeah.
I learned a lot of things from Dr. Otsubo. So when I started SEG in Nagoya University, I asked Dr. Otsubo, what do you think in the SEEG? He said the SEEG has a lot of complication, including the hematoma some things. What do you think about the SEEG? It's very safe, yeah.
Yeah, that's great. So I can say in North America, maybe like Japan now, we're moving away from subdural grid monitoring to stereo EEG monitoring because of the safety, essentially, and because children do so much better after SEEG electrode implantation. They go home like immediately after surgery, or they're awake and totally responsive right away after surgery. They don't need to stay in the intensive care unit. There is a small risk of hemorrhage for sure, but what we found is careful planning of the EEG entry, through the skull and avoiding contact with any surface vessels and depth like arteries will keep it safe. But that requires a lot of planning, and we spend hours planning these cases as neurosurgeons, and the neurologists don't understand what's involved. But it's really important that you plan your electrode trajectory perfectly so you avoid complications.
Okay, thank you. Thank you for your answer. The question or comment from listener?
Yeah, definitely. We'll open the topic for discussion. I would like to invite the comments from our panelists.
Professor Zamzuri here. Have you come across patient with a refractory schizophrenia, and then some elements of probably epilepsy in it as well? So the psychiatric side argue that it's refractory to medication, and then the neurologists say not sure about the epilepsy. Is there epileptic spike on the scalp EEG and so on? So I'm talking about the refractory schizophrenia with some sort of epilepsy in it. Have you come across? Have you done stereo EEG or invasive EEG for such patients?
Yeah, you know,
thank you.
that's a very good question, Dr. Idris. Thank you. I personally have not got such a case in my practice or experience, but in the adult centers in Toronto, I know they are very interested in trying to map out where schizophrenia has its target. And it's become an interesting discussion for deep brain stimulation, you know, trying to avoid open surgery. And if you can modify the network of chemical imbalances that occur with schizophrenia, you might impact favorably on that disorder. Its association with epilepsy, though, is complicated, and I don't know. I'm not very familiar with literature that shows us best how to take care of these patients. So I don't have an example in my practice, but I'd be interested if you've tried it. If you've tried SEEG, it'd be good for I think everybody to know today.
Okay.
Thank you.
Thank you, bro. Thank you
very much. There is one question from the audience. Dr. Fabiano Santoso asks, how about the use of gamma knife radiosurgery?
Yeah, thank you for your question. Yeah, so for just take the example I showed of hypothalamic hamartoma. There's a literature on gamma knife radiosurgery for hypothalamic hamartoma. I would say that it can be done. It's somewhat useful, but it's not as effective in my experience, and also I think in the published literature, as laser ablation or even radiofrequency. Just so you know, hypothalamic hamartoma was very challenging. We started doing open resections of those many years ago. Then we moved to endoscopic disconnections. Then we moved to laser ablation. And of all those strategies for hypothalamic hamartoma, laser is probably the best. But there are a number of groups, especially Régi's group in Marseille, I think in France, has used a lot of gamma knife radiosurgery for hypothalamic hamartoma with decent results, but I don't think they're as good as laser.
Right. Yes, my co-host, Dr. Liu Boon Seng, would you like to ask something?
Raja, thank you, Professor. I wish to find out, Professor, regarding the timing for intervention. In most of the cases, do you really wait for so-called medically refractory seizure, or you tend to treat them earlier? My second question, Prof, do you have any idea what is there any role to use a high intensity focused ultrasound, which are now very popular? And my last question, is there any way to develop AI to detect cortical dysplasia? Thank you, Professor.
Yeah, thanks. All very, very good questions. Yeah, we usually don't wait long. If there's a lesion that's identifiable, it's causing epilepsy, and a child is already needing one drug or two drugs, we probably wouldn't wait that long. And so in the presence of a lesion, and you have epilepsy clearly, I think a lot of data will tell you don't wait for refractory kind of multiple medications. Just go ahead and take care of the lesion. It'll help the epilepsy better than anything else. So we usually don't wait that long a period of time. One of your questions was also about high frequency ultrasound. So we actually have two HIFU units in Toronto, and I have one case of hypothalamic hamartoma, one of these massive, large hypothalamic hamartomas that we tried to obliterate with laser, but it was so complicated and it got so scarred, we weren't able to pass another laser probe into it. So instead, what we did was we made this child a candidate for high frequency MR-guided focused ultrasound ablation. And that's a good technique because, you know, you can do very, very targeted ablations for functional disorders, essential tremor, Parkinson's, and so on with with the MR guided focused ultrasound. So in select cases for epilepsy now, we're thinking of using that. And then your final question was about, are there any biomarkers essentially for focal cortical dysplasia? And as yet, nothing has arisen, but I think with 3 Tesla, now going to 7 Tesla MRI scan, I bet we'll be finding more and more cases of cortical dysplasia as the cause of epilepsy than we've ever seen before. When we resect epileptic lesions in children, often we don't see a lesion, but when we take the pathology out, the pathologist will find something that's kind of microscopic. So I'm hoping that the latest MR imaging will guide us towards making that diagnosis faster and better.
Thank you, Professor.
Yes, Professor Anil Pitambara, would you like to ask?
There's an excellent procedure you did in a hypothalamic hematoma. What I would like to know is, are you using artificial intelligence or robotics to keep it contained within that zone? And how do you plan the trajectory to reach there?
Yeah, so we're going to be moving soon to robotics for the laser cases. Right now, we're using a Lexel frame based, but the actual Monteris device has a robot attached to it, so it can robotically advance the laser probe right to target and can move it in different directions once it's inserted. So that's the advantage of the Monteris device itself. So it's pretty good that way. But the thermography that I showed you on the video is pretty precise, and that's how we know we stay within target, is by following the thermal patterns that arise after the laser has started. And so we don't need to rely on artificial intelligence or other strategies, because the laser thermal program software that's embedded in the laser package is so good, it'll keep us safe all the time. We've not had a case where our laser burn has gone beyond the boundaries that we set for ourselves.
Okay.
Thank you, Anil sir. Thank you, Anil sir, for joining. I think if there are no more questions, we can go back to our chair to have his concluding remarks. Yes, Professor Kajita.
Okay, thank you for a good lecture. Very useful lecture. So in Asian countries, so we would like to follow. So you are great advance in epilepsy surgery. Thank you once more.
Great, thanks everybody. Real pleasure. Nice to see everybody.
Thank you very much, Professor Rutka. So we'll move on to the next topic. It was indeed a wonderful talk. We learned a lot from your lecture. Thanks so much. For the next lecture, I would like to invite the second chair, Professor Tomohiro Yamaki.
Hello, everyone. Thank you very much for coming this session. And this lecture is 40 minutes, and after lecture, the 5 minutes short discussion. Is it okay? So my name is Tomohiro Yamaki. I'm a director of Rehabilitation Center for Traumatic Epilepsy Chiba in Japan. Wow, this session is topic for the disorder of consciousness. The speaker is Dr. Mitchell Farrisko from Uppsala University, Sweden. So he's one of the research leader, the disorder of consciousness special interest group of International Brain Injury Association. Wow, could you start, please, Dr. Farrisko?
Yeah. Okay. Thank you. Thank you, Professor Yamaki, and thank you also to Raja and the president of Professor Kato of the ACNS. This is a very nice, terrific opportunity for me to present the research we are doing both within Europe and also within the International Brain Injury Association. I am a philosopher as a background, so you can imagine my lecture will be slightly different than the preceding one. I hope it will be interesting, at least not as the preceding one, but at least just enough to not annoy you. So I'd like to share my presentation. Let's see if it works. Can you see it? Okay. So the title of my talk is American and European Guidelines on Disorders of Consciousness, a Neuroethical Commentary. So basically, the outline of what I will present you is the following. So I will very briefly introduce the concept of neuroethics as a discipline. And also I will summarize the two guidelines in question, the American and the European guidelines on disorders of consciousness. And then I will present some illustrative neuroethical issues arising from disorders of consciousness and also from what these two guidelines say about these conditions. And then I hope to have a brief discussion with you. Let me say since the beginning that my very great desire will be to continue this exchange of ideas even beyond this lecture. So I will be very pleased if you, for instance, can send me an email with your feedback, or we can continue the exchange of ideas about these issues. So concerning neuroethics, as the label also suggests, neuroethics is an ethical reasoning, an ethical analysis of neuroscience, very broadly conceived. In a recent article I wrote together with two colleagues from Uppsala University in Sweden, we identified three main meanings of neuroethics, which are neurobioethics, empirical neuroethics, and conceptual neuroethics. Since its formal introduction in 2002, neuroethics has been conceived as either ethics of neuroscience or neuroscience of ethics, meaning an ethical analysis of possible issues arising from neuroscience or an analysis of how neuroscience can help us to understand traditional, we might say also philosophical issues, like for instance, what does it mean morality, or when an action is ethically good or bad. We think that this understanding is, of course, valid, important, but not complete. And so we suggest these three meanings of neuroethics. The first, neurobioethics, basically applies ethical theory and reasoning to practical issues arising from neuroscientific research and also from the clinical applications. So neurobioethics is primarily normative in the sense that it aims to define we might say, the right action to take. So it aims to define what is, to disentangle what is good and what is bad. So this is, we might say, the traditional meaning of neuroethics as ethics of neuroscience. And it is very close also to bioethics as traditionally conceived. Then we identify the second meaning of neuroethics, which is empirical neuroethics, which uses empirical data to inform theoretical and practical issues. So this second meaning of neuroethics is descriptive and occasionally explanatory, meaning that it aims to describe how we act in a certain way, and also it aims to explain why we behave in a certain way. So it is what is traditionally described, we might say, as neuroscience of ethics. But we also identify a third important meaning of neuroethics, which is conceptual neuroethics, which uses conceptual analysis of key notions to address issues such as how neuroscientific knowledge is constructed and why and how empirical knowledge of the brain can be relevant to philosophical, social, and ethical concerns. I mean, this third level of analysis is, we might say, more philosophical in the sense that it doesn't take for granted that neuroscience is relevant to, philosophical, social, and ethical discussions, but it tries to explain why neuroscience is relevant to this kind of issues. So in this sense, it is a theoretical, engagement, theoretical work. So this was just a very brief and quick premise about the concept of neuroethics. What does it mean to ethically analyze and reflect upon neuroscience and relevant clinical applications? I'm currently coordinating a survey within the International Brain Injury Association, which is a survey about how clinicians apply disorders of consciousness guidelines in their ordinary work. This survey is part of the work of the Disorders of Consciousness Special Interest Group, which is a subgroup of the International Brain Injury Association, a subgroup which was created quite recently, a few years ago. You here see some names of the coordinators and also links and possible contacts if you have any specific interest in joining this group. There are already some people from Japan in this group, and so there are some people from your association as well representing in this subgroup. So as part of this subgroup, we have this project about the guidelines on disorders of consciousness. But I'm also working within the Human Brain Project, the European Human Brain Project, which is a huge project launched in 2013, which include different specific disciplines and approaches, from neuroscience to robotics to artificial intelligence, computational neuroscience, and also philosophy. In the last phase of the project, philosophy is embedded in scientific work packages. I'm personally involved in 2 scientific work packages, one about consciousness and specifically about disorders of consciousness, and another about artificial intelligence. So I'm part of a multidisciplinary project trying to make some advance in the analysis of disorders of consciousness. So just as a premise, what are disorders of consciousness? I'm sure you already know this, but I'll be very quick on this. So following a brain injury, but not necessarily for a brain injury, you can have a coma, and the coma can be followed by different disorders, conditions, which are unresponsive wakefulness syndrome. We use in Europe this label in replacement of vegetative state. The vegetative state, or unresponsive wakefulness syndrome, can evolve in minimal conscious state, which has been also divided in minus and plus, because the patients can manifest some residual behavioral activity, so to say. But the coma can also evolve in functional lock-in syndrome or in lock-in syndrome. So we have a quite, a broad group of possible conditions following the brain injury, or anyway the coma. But this, of course, this slide has not an absolute value, because the nosology of disorders of consciousness is still an very open question. So it is very hard to define absolute and fixed categories to use to describe these conditions. So discussion is very open about that. Okay, so just a very quick now summary of the 2 guidelines. I start from the European guidelines. These European guidelines has been published in this article that you can access and read if you are interested in more detailed information. And these European guidelines have been endorsed by the European Academy of Neurology, and they are about diagnosis of coma and other disorders of consciousness. So the purpose of these guidelines is to provide the state-of-the-art evidence regarding the diagnosis of disorders of consciousness, summarizing data from bedside examination technique, but also from functional neuroimaging and electroencephalography. So these guidelines focus both on behavioral assessment of these patients and technological assessment of these patients. This is an important point. I will go back later. Regarding the methods used in these guidelines, basically involving different European countries, 10 European countries, they performed a review of scientific evidence for the evaluation on coma and other disorders of consciousness. So basically it's a review-based guideline. And the conclusion is that the standardized clinical evaluation, EEG-based techniques, and functional neuroimaging analysis should be integrated for a multimodal evaluation of patients with disorders of consciousness. This is the main recommendation of the guideline, to use both behavioral and instrumental evaluation of disorders of consciousness. And they also recommend that the state of consciousness should be classified according to the highest level revealed by any of these three approaches. So if there is no agreement between the three approaches, the highest level revealed by any of that should be taken as the actual state of the patient. So the European guidelines include three main sections or focus, which are the clinical examination, the functional neuroimaging, and the EEG-based technique. And they have also specific focus about TMS, transcranial magnetic stimulation, EEG, and evoked potentials. So concerning the first section or focus, I just here report some of the recommendation of the guidelines, not all the recommendation, but some of the recommendations. So one of the recommendation is that since the coma recovery scale revised, if freely available, it is recommended that it is used to classify the level of consciousness. So the European guidelines recommend to use the coma recovery scale revised as a behavioral scale to use in order to classify the level of consciousness of these patients. And another important point is that the classification of consciousness level should never be made based on an isolated assessment. They explicitly recommend to repeat the assessment several times according to the specific condition of the patients. Of course, the medical doctor has the final choice or how many repetitions to do. So that depends on the specific clinical conditions. But the point is to avoid an isolated assessment of the level of consciousness. So to repeat the assessment more than one time. Also, the guidelines recommend to use the full outline of our responsiveness to assess the level of consciousness in the intensive care unit instead of the Glasgow Coma Scale. So they recommend to replace the Glasgow Coma Scale with the 4 score. And also they suggest to use the nociceptive coma scale revised for regular monitoring of signs of discomfort. This is an important point. I will return to it because the issue of pain and suffering in these patients is an ethically very relevant point because it is very tricky and very difficult, of course, to assess how much pain these patients can feel, can experience. So it is crucial to implement all the possible assessments in order to clear that point. Okay, so these were just some illustrative recommendations regarding the clinical assessment of disorders of consciousness. Then we have the other focus, which is about the functional neuroimaging. The European guidelines recommend to focus also on resting state assessments, to use specifically fluorodeoxyglucose PET they say that might be considered as part, again, of a multimodal assessment in unresponsive patients. So this multimodal assessment is a returning concept that the European guidelines outline. They recommend to use different approaches, as I already told you. Also, they recommend the use of resting state fMRI. So the resting state assessment might be performed using both PET and fMRI according to the European guidelines, but always as part of a multimodal assessment. But they also recommend active fMRI paradigms, so not only focusing on resting state, but also using active paradigms, so assessing how much the patient is able to respond to external stimuli. So they recommend to assess residual ability of the patients to process and to saliently respond to external stimulation, always as part of a multimodal assessment, of course. It is important that these active paradigms are used in patients that do not show command following at the bedside. I should mention here that, of course, in the last years, the diagnosis of these patients has been changed quite a lot. I mean, because they discovered the possibility of covert residual consciousness. So it is possible that these patients are still conscious, even though they do not show behaviorally their residual consciousness. And so to detect this covert, this hidden residual consciousness, it is necessary to go beyond, of course, the behavioral assessment. And so in this sense, active fMRI paradigms, as well as resting state fMRI or PET paradigms, are very important. So the diagnosis of these patients became even more challenging after this important result. Okay, so concerning the EEG-based techniques, the European guidelines do not recommend the use of non-visual numerical analysis of standard EEG for the differentiation between vegetative state or a responsive wakefulness syndrome and minimally conscious state. This is another ethically very important point, because it has been shown that about 40% of patients in intensive care unit, I mean disorders of consciousness patients in intensive care units, are wrongly classified as vegetative state rather than minimally conscious state. So we have a big ethical problem of misdiagnosis of these patients. And this is also clinically very important, because of course the healthcare paradigm for a vegetative state patients is importantly different than a patient with minimal conscious state, and also the prognosis is very different. So it is crucial to rightly diagnose these patients, and this is an important point that we will see also in the American guidelines. Also, concerning the EEG-based technique, the European guidelines suggest that sleep EEG might be used for the differentiation between a vegetative state and responsive wakefulness syndrome and minimal conscious state. So this focus on sleep EEG is also very important in order to find a way to distinguish, to disentangle between vegetative state and minimal conscious state. Also, the European guidelines suggest that quantitative analysis of high-density EEG can be considered for the differentiation, again, between vegetative state and minimal conscious state. And also cognitive evoked potential can be used for this differentiation, and the TMS EEG should be considered for the differentiation between vegetative state and minimally conscious state. This TMS EEG has been introduced quite recently, and it is giving very important results in terms of diagnosis of these conditions, but also as a ground for a better prognosis, for better therapeutic plan for these patients. Another important recommendation that I thought it was important to outline and to stress is that multi-center collaborations are needed in order to provide the better diagnosis, the better prognosis, and also eventually the better therapeutic plan. So the European guidelines recommend to have a collaboration among different centers, of course, also from different countries. And this is a crucial point. So these were just some illustrative recommendations from the European guidelines. Let's now consider and focus on the American guidelines. American guidelines that have been endorsed by the American Academy of Neurology together with the American Congress of Rehabilitation Medicine and the National Institute on Disability, Independent Living, and Rehabilitation Research. So we have 3 institutes collaborating for these guidelines. So the purpose of these guidelines is to update the 1995 American Academy of Neurology practice parameter on persistent vegetative state and the 2002 definition of minimally conscious state, as well as to provide care recommendations for patients with prolonged disorders of consciousness. I mentioned it before that the nosology of disorders of consciousness is still an open question, and it is dynamic. It is changing because, of course, research is progressing. We know more than 20 or 30 years ago. And so accordingly, we change the label, the categories we use to describe these conditions. And so these American guidelines have been conceived to update the language. And this is important because the language has also, of course, clinical, but also ethical implication. The way we name these patients impact the way we think about them. And so eventually the way we decide about how to treat them. An important point that we should consider is that these American guidelines are focused specifically on prolonged disorders of consciousness. So on patients that are in disorders of consciousness since more than 28 days. So the focus is more specific than the European guidelines. Even in this case, we have review-based guidelines. So basically, they performed a review of available data. So the American guidelines provide 18 recommendations plus 5 sub-recommendations, so to say. And these recommendations are organized in 4 groups. So the first is about overall care and diagnosis for adults with a prolonged disorders of consciousness. The second group is about that prognosis for adults with a prolonged disorders of consciousness. The third group is about care and treatment for adults with prolonged disorders of consciousness. And the last one is about care for children with prolonged disorders of consciousness. It is important, this specific focus on children, because again, the prognosis is slightly different in children population than in older population. I now provide just, even in this case, illustrative recommendations from the guidelines. An important recommendation is that clinicians should identify confounding conditions, optimize arousal, and perform serial standardized assessment to improve the diagnosis diagnostic accuracy in adults and children with prolonged disorders of consciousness. So there are kind of preliminary actions that the clinician should take in order to optimize, the diagnosis of these conditions. So something that the clinician should take care of before performing the diagnosis. The American guidelines, differently than the European, stress with an important emphasis the need to counsel families of these patients. So to involve families in the clinical decision about these patients. They explicitly stress the need for good communication with families. And they also provide quite specific recommendation about how to communicate with families. For instance, they recommend to clinicians to inform families that we might say the etiology, I mean the prognosis of disorders of consciousness is different if you have adults rather than children, and if you have traumatic rather than non-traumatic disorders of consciousness. So they provide pretty specific indications on how to communicate with the family. Also, they recommend to use different kind of technology to assist the prognosis. And also they recommend to assess these patients in order to detect possible evidence of pain and suffering, and to treat when there is reasonable cause to suspect that the patient is experiencing pain regardless of the level of consciousness. But even in this case, they include also specific recommendation about how and what to communicate to the family. In fact, they recommend to counsel families that there is uncertainty regarding the degree of pain and suffering that might be experienced by patients with a dog. This is not trivial, nor, it is important to acknowledge the uncertainty about this situation and to rightly communicate uncertainty to lay people, like in the most cases are the families of these patients. So it is important that clinicians acknowledge that they have in front of them people that do not understand the technical details of what is going on, and especially they do not understand what is the meaning of statistical, for instance, information, and how much relevant is that statistical information for their loved patients, So it's important to communicate in the right way the uncertainty surrounding this medical information. They also recommend specifically about counseling concerning children, acknowledging, for instance, the natural history of recovery, prognosis, and treatment that are not really established. So even in this case, it's important to rightly communicate the uncertainty surrounding this situation. And also, this is an important point. They recommend to replace permanent vegetative state with chronic vegetative state. So the concept of permanent vegetative state is recommended to be removed because it might wrongly suggest that this situation is static. So it's something, so to say, forever, while recent evidence show that it might change. So it is not actually permanent. So in this sense, they recommend to replace permanent vegetative state with chronic vegetative state. And this is in line with a precautionary principle, we might say, from an ethical point of view. And it is also very important, ethically speaking, more broadly. Another interesting recommendation from these guidelines is that the care for patients with prolonged disorders of consciousness might benefit from multidisciplinary rehabilitation specialists. So they recommend to take care of the rehabilitation plan. Even in this case, this is something to stress, because sometimes it happens that these patients are not, included in rehabilitation program, especially if you take, the permanent vegetative state as a prognosis, and so you assume that the situation is stuck in a way. It's forever. So it's important that these guidelines basically suggest a new way of thinking about these disorders of consciousness. They suggest a dynamic concept of disorders of consciousness, and this has important ethical implications. Also, they recommend serial standardized neurobehavioral assessment. So even in this case, like the European guidelines, they recommend to perform more than one assessment. And also, of course, they recommend to identify both patients and family preferences early and throughout, of course, throughout the process of care. This is also an ethical important point. I will say something more on this later. And again, they recommend to counsel families about the limitation of existing evidence. So in general, overall, these guidelines give an important role to precaution, to be very in this sense honest about what we know, but also about what we do not know, and to communicate this in a transparent way to the families. So now just some illustrative ethical issues. I would like to refer to this paper first, which has been written by Joseph Fins and James Bernat. Both are, of course, giant experts about disorders of consciousness. And this paper specifically is kind of a complementation of the a complement of the American guidelines with a specific focus on ethics. And there are some interesting points stressed in this paper. The first point, which I already mentioned to you, is the problem of misdiagnosis. I already told you that up to 40% of minimally conscious state patients are misclassified as vegetative state in the intensive care unit. And this is something very, this is a very big problem. I mean, both from a clinical and from an ethical point of view. This article also stresses the ethical issue of medical mismanagement. So the possibility that, for instance, you assume disorders of consciousness as static, and so you exclude the possibility of recovering of these patients. And so this is a case of medical mismanagement. And also another important point stressed by this article is the wide unavailability of skilled care by knowledgeable practitioners. So the point is that these guidelines, I mean both the American and the European guidelines, recommend a multimodal assessment using both behavioral, I mean clinical, and technological assessment like fMRI or EEG. But some technology is not that easy to use. And so you need, of course, skilled person, you need, people able to rightly use and to rightly interpret the results that you get with this technology. And especially in ordinary, so to say, hospitals where you do not have research activities, but you have ordinary, I mean, clinical settings, it's not that easy to have, these skills, to have people able to really use this technology. if you have this technology at all, because it is also not, I mean, not that easy to have this technology available in all the hospitals. So an ethical problem to consider, to take into account, is how much these guidelines can be implemented in practice. So how much these guidelines can be really translated in clinical activity. And this is one of the main points that we would like to explore with the survey we are coordinating within the International Brain Injury Association. Another point stressed by Fins and Bernard is that about 20% of patients in vegetative state evolve in minimally conscious state. This has, of course, important implications for a number of issues, for instance, end-of-life decisions, because traditionally, the withdrawal or life-sustaining treatment has been based on the reversibility and futility of vegetative state. We have different quite popular cases. For instance, in America, Kimlan case was the first where actually the withdrawal, I mean, decision to stop care for these patients was based on the fact that the vegetative state was irreversible. So was, you know, conditions that could not be reversed, could not be changed. But there is now, there are new data showing the opposite, that these conditions are dynamic. So what is the ethical implication, the clinical and ethical implication of this? And this is important to take into account. We also need skilled communication with patients and surrogates, families, in order to really enhance the decisions about, you know, the care for these patients. So it's important to take care of communication, as I already told you. And another important point stressed by this article is the need for translating aggregate statistical data into care decisions for individual patients. How can we translate statistical data into personalized healthcare protocols? This is not, you know, that easy. Also, we need to engage the recovery patient in conversation about care, even though they do not regain legal competence. Well, here we have different concepts to take into account. Of course, with some stage of the, you know, of the proof experiments, for instance, by Owen in Canada, it was possible to implement a kind of rudimentary communication protocol with patients in disorders of consciousness through neuroimaging. So the doctor, the clinical doctor, asked the patients, for instance, to imagine playing tennis rather than imaging to move around his house. And when the patient imagined to playing tennis, a specific brain area was activated. When he imagined to move around her house, another brain area was activated. And so the doctor was able to set a kind of communication protocol, telling to the patients, if you want to say yes, then imagine to play tennis. If you want to say no, then imagine to move around your house. And so in this way, kind of brain-based communication was, you know, performed. So from an ethical point of view, the question arises whether this kind of brain-based communication is enough, is sufficient to include the patient back in decision regarding his, you know, his care, his clinical care. For instance, you can imagine to ask these patients, would you like to withdraw life-sustaining treatment, or if yes, imagine playing tennis. And then this is something very huge. I mean, this is something because you are asking these patients basically if you want to keep to be kept alive or not. So it's not that easy to say that yes, these patients can be put back in the process, in the decisional process, because you don't know really what is going on in his brain and in his mind. So it's very tricky, very challenging. Another ethical important point is the disability paradox. This means that we usually have a tendency to rate the quality of life of people with, with a disease, for instance, or a disability, lower than how those people actually rate themselves. So there are also research out there showing that people with lock-in syndrome actually rate their life not so bad, so quite good. They rate their conditions not so terrible after all. And this is important to take into account. That, I mean, observe from the external, of course, the situation of these patients is really bad, because they lie in a bed, they do not have, the possibility to enjoy the usual ordinary experiences that we enjoy in our daily life. But we should not exclude that they have a different kind of enjoyment, so to say. So they have a residual positive experience in their condition. And this is called the disability paradox. And another ethical important point is the availability or not availability of the infrastructure necessary to provide timely and informed care. So this is also an ethical important, but not only ethical, also clinical important point. I'm going toward the conclusion. I just want to mention another article which is important to have an idea of possible ethical issues arising from these situations. This article is from 2019, written by Melissa Armstrong, and it is specifically about how to develop the disorders of consciousness guideline. And this article stresses a number of obstacles in order to implement the guidelines. The first is the clinician knowledge and awareness of the guidelines. How many clinicians working with disorders of consciousness really know the guidelines? Another is the attitude toward the guidelines. It is possible that a clinician knows the guidelines, but does not agree with them, because the guidelines are not law, right? So they have recommendations. They do not, of course, it is not, I mean, you are not obliged by law to follow them. So also the attitude toward the guidelines can make a difference. And also the ordinary clinician behaviors, of course, can be an obstacle to implement the guidelines. So the main point is if and how these guidelines can be implemented in practice. I would like to illustrate a model for what is called shared decision making. So you have a kind of communicative process, we might say, in different steps, 5 steps basically. So the first step is to identify the decision that needs to be made. So you can have different kind of decisions that you need to take, in the clinical care of the patients. That the second step is to assess values and preferences of the patients, or in order to assess the patient's preferences, you can use, of course, the surrogate or the family. If the patient's in conditions according to which he is enabled to provide his own values and preferences. Then, of course, you need to provide the best medical evidence. So to provide data as, we might say, neutral as you can be. So to provide scientific evidence of what is going on. And then, of course, as a kind of collaboration between the patients or surrogate and the clinicians, you need to make finally the decisions and then to reassess the decision. So this is a model for what is called a shared decision making, so a communication process in order to really involve the patients in the loop, in the process. In this table, you have the comparison between different models of decision making. You can have what is called a parentalistic, where the clinicians is assumed to be the only one able to really take the decisions, and the patients cannot be trusted to choose well from themselves because they are not skilled enough. Or you have another model called the clinicians as best agent, where the assumption is that the clinicians can know patients' preferences well enough to make the same decision that the patients will make. So in this case, the patients is mentioned, but still the clinicians is in charge of the final decisions. And then you have this shared this decision making, where patients and clinicians are able to partner, to collaborate, to integrate information from both parties to make the final decision. So the point is how to implement a shared decision. And this is basically recommended by especially the American guidelines. In conclusion, I just want to mention an article I wrote some years ago about the issue of pain, because the American guidelines recommend to use Ferns and Bernat, as they write, when in doubt, it is not preferable to presume covert consciousness in order to assure the prevention of pain and suffering. So what the American guidelines and also these commentators recommend is to use, we might say, palliative care, so painkiller, always presuming that the patients feel pain. I don't think this follows from an ethical point of view, because always using painkillers can raise the risk to reduce residual awareness. So you can make, a bad, I mean, you can make a bad choice, because you can even further reduce residual consciousness. This is just to give you an example of the fact that these kind of decisions are really challenging, and it's not that easy to make the right one, of course. There are a lot of factors to take into account. To conclude, I would like to invite you to send me your feedback, if not now, of course, in conversation, even by email. And also, I have a request for you, because in this survey with the International Brain Injury Association, we are focusing on American and European guidelines, but we would like to include also other guidelines, for instance, from Asia, if there are, because I'm not aware of them. So if you know about possible guidelines to include in this survey, I will be very grateful. And so thank you for your attention.
Thank you very much for wonderful lecture, Dr. Farrisko. So is there any question from audience? Okay, so I have one question. So frankly, neurosurgeons tend to focus on the treatment in acute phase. So such as surgery or endovascular surgery. But I think it is important for neurosurgeons to commit to participate the assessment in chronic phase, because they have a lot of knowledge for the assessment for the patient with disordered consciousness, and a lot of knowledge of neuroimaging, neurophysiological technique, or something like that. So my question is there any strategy for the dissemination of a guideline, EN or AN guideline for the variety of type of clinician? Do you have any suggestion?
Yeah, this is an important point. I do not know specifically about any strategy to target different clinicians and so to disseminate the knowledge of the guidelines among different clinicians. What I know is that especially the American guidelines stresses that there is, of course, there are differences between the intensive care unit and we might say the long-term chronic unit, but they stress that there are also commonalities. So they stress the importance, as you rightly say, to collaborate between clinicians working on one side and on the other side. I do not know, frankly, about specific strategies to disseminate the knowledge of the guidelines, but this is, I think, a crucial point that should be considered. Yeah.
Okay, thank you. And second point, please tell, if you have, please tell us what is a careful point when you make a correct assessment of patient with disorder of consciousness, because sometimes how to say the disorder of consciousness have a problem of arousal awareness dissociation. So when we check the neurology for the patient, sometimes the patient present a good neurology, but the other days is not. So the condition of the consciousness condition is fluctuating, right? So do you have any technical tips for correct assessment for patients?
Well, I'm as I told you at the beginning, I'm not a technician. I'm not a clinician either. I am a philosopher. So I just report. I mean, I read these guidelines and I try to develop a kind of ethical analysis. But what emerges from these guidelines is the importance to perform repeated assessment using different modalities. Because of course, with these patients, it is possible that you assess awareness where, for instance, the patient is sleeping. And so you have a result. The day after you perform, another assessment and you have a completely different result because in that moment, the patient was in another condition. So what these guidelines recommend is to repeat the assessment several times and also using different protocols. So behavioral and instrumental assessment. I'm sorry, but I do not have technical tips on how to perform that.
No, but you give it for neurosurgeon to the big important point. So it is very important to check the mulch point, right?
Yes.
Okay,
that's crucial. That's very important. Yeah.
Okay, thank you very much.
Prof. Michel, from me, Idris.
Hi, Idris.
Yeah, just asking because you are more like philosophy sciences. So I wonder about consciousness. Do you think about the quantum brain is also important for consciousness? View the brain as totally wave, not as anatomical brain, but as whole thing is a wave. Is a second view of the brain.
Wow,
what do you think about that quantum?
That's fascinating. I know about also theories about, of course, quantum theories about consciousness. I'm personally a brain-based. I mean, I personally see the brain in terms of neurology, and so I am tied to this view of consciousness. But I am fascinated as well from these other perspectives. But I wonder how it might be clinically translated, this view of the brain in terms of waves. So, I mean, the so to say, neurological view of the brain has an immediate clinical relevance. And of course, it is used daily in your work, I mean, with patients. How do you think that a view of the brain in terms of waves can be translated in clinical context.
Yes, good point. I just wonder in terms of like quantum field. So probably at this stage we still don't have technology to measure the quantum field. Now we measure about the electromagnetic field, which arising from the chemical response. But probably we don't know explore yet about the hidden energy. I mean, the science is not that level probably yet to measure the quantum field. Probably the fusion of the quantum field and electromagnetic field might play a role in psychiatry as well. Yeah, that's my view. But it's interesting, but we're still at the superficial level about the quantum field.
Yeah, as a philosopher, I must confess, this is something that really fascinates me. But on the other hand, I also am an ethicist. And so from an ethical point of view, I think that the neurological view of the brain is, at least to date, as you say, more useful in the clinical context. Maybe because our knowledge is limited, after all.
Okay, thank you.
Thank you very much. We have far exceeded our time. I would like to invite our chair to give his concluding remarks. We can close. Please give your concluding remarks.
Okay, so when we will close this session, I appreciate Dr. Raja for preparation this meeting, and I appreciate Professor Kato, and thank you very much for the wonderful lecture for Dr. Farrisko. Thank you very much.
Thank you very much, Professor.
Thank you.
With that, I would like to conclude this officially on behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato. I would like to thank both the speakers for today, Professor James Rudka and Professor Michelle Farrisko, and the chairs for today, Professor Tomohiro Yamaki and Professor Yasukazu Kajita, for coming here and spending their time with us and teaching us. So until we all meet on next Saturday, it is bye-bye from all of us. Thank you all the distinguished guests who joined us for today. Thank you very much.